I'm from Western Australia. I've got a psychology background, and I'm happy to be presenting the results of this study so far to you. I'm just going to give you a little bit of a background. I'm preaching to the converted, but clinical guidelines suggest that palliative care should be available to people with MND and their families as part of a multidisciplinary approach. And this is essential or important to establish relationships before symptoms become exacerbated and before the terminal phase of MND. Yet despite these guidelines, certainly in West Australia, maybe different in other parts of the world, and I'd like to hear about that, families, people with MND and their families and their carers really find it very difficult to access palliative care services when needed. And there's a whole range of reasons for that. And they often state that they have unmet support needs towards the end of life. Some of these barriers are that the service provisions in Western Australia are really quite strict, and they require a limited life expectancy and a clear prognosis. Yet estimating prognosis in MND, as everybody in the room knows, can be difficult, and decline can be extremely unpredictable. So also palliative care providers may mistake some of the necessary feeding and breathing support for symptom control as life-sustaining, and may perhaps be reluctant or ambivalent about providing care. Others may be reticent to provide service to people with high dependency needs. I think our community-based palliative care service has a limit on the number of people with MND in their service at any particular time. So there are quite often restrictions there. And also the relative rarity of MND results in fewer opportunities for experience and to learn the knowledge that you need. So there are a number of barriers for this. However, people with cancer, it's more predictable, they're more traditional recipients of palliative care. I think, again, in our community-based palliative care service, it's something around 83–84% of people receiving palliative care have got a cancer diagnosis. The needs of people with cancer, because of the ongoing experience and also the more predictable trajectory, are much better understood and managed by palliative care professionals. And so they're able to access palliative care services substantially higher rates than people with non-cancer. Just as an example, in Western Australia, 66% of people who died of cancer had access to palliative care services, compared to 10% of people who died from non-malignant conditions. And I think those statistics are from about 2 years ago. They may have changed slightly, but they'll be around that. So the argument we came up with, or the discussion, the ideas we came up with, and it was actually in a multidisciplinary team meeting at one stage, is that this may lead to differences in the end-of-life experiences for people with cancer and people with other life-limiting illnesses, such as MND. Despite the challenges, there is a lack of research, and there's certainly a lack of comparative research. So what we did was we aimed to explore the experiences of family caregivers of people with MND and people with cancer in Western Australia. So these are bereaved family caregivers. So it's through the lens of caregivers, but they were relating the experiences at the end of life and death. And we wanted to highlight similarities and differences between the two groups. We did a qualitative study, and we focused on people's own interpretations and views. Participants were over the age of 18, could communicate in English, and were bereaved from between 3 and 15 months. As a little side study in this particular study, we looked at when people would be willing to talk about their experiences after bereavement. And many people said earlier than 3 months, but our ethics committees were very reluctant to go before 3 months, so 3 to 15 months. And we had 12 MND carers of MND, people with MND, and 10 carers of people with cancer. We try and match the cancer sample, so we had certain criteria there. My main focus is trying to give you some of the supports. There were some of the results. There were many positives and there were many similarities between the two groups. But I'm going to focus on 3 different themes that really made up differences between the two groups and were really unique to people with MND and their carers. So many MND family carers reported problems in accessing adequate support at the end of life, and some felt they were not seen often enough at the MND clinic. So if I was going to make a criticism, it would have been the fact that because her progress through the disease was reasonably rapid, more frequent visits would have been better. Others said they did not receive the desired palliative care services. I was really angry with palliative care services. I thought they let us both down terribly. You'd think they would have helped me knowing that he didn't have much longer to live. Some people received palliative care services for a short time, and then these services were taken away, probably because of the strict criteria, the high numbers in community-based palliative care, and the restrictions around that. So there were lots of reasons, but this had a huge impact on families. There was a day when the palliative care nurse came and said, "Oh, I don't think we can come anymore." I said, "Do you think that's fair on me?" Some participants believed that palliative care providers lacked sufficient knowledge and training about MND. The palliative care people got someone to come out one night to give me a break. And then I spent the night getting up. They kept coming and waking me and saying there's something wrong and he's not settling and they can't turn him. They weren't qualified people. In contrast, and as I say, these were the things that were different about the two groups. In contrast, even though some of the family carers would have liked, of cancer would have liked palliative care services to begin earlier, I probably should have asked for a referral. Sorry, I've got aeroplane voice, I think. I should have asked for a referral to palliative care earlier rather than waiting as I did and assuming that the GP would do that when the time was right. But others said that they were offered services before they were needed. We didn't have to ask, it was just there. So they kicked in. It was just a more direct and easier journey. A few family carers were offered more support than they felt they needed, and they actually declined some services. I was asked, did we want people to come and do the housework for me or anything else? And I said, no, I don't need it. Community palliative care services were very good, and they offered us extra services if we wanted them. So you can see the contrast there. Accessing information, so relating back to case talk this morning, many MND family carers had difficulty or articulated difficulties in accessing information about end of life and end of life decisions. Some reported that no one discussed end of life or death with them. No one talked to me about it. I wasn't aware of what to expect in those family stages. I did start to read more on my own, but no one offered help. Others reported that their healthcare providers said they could not predict what would happen. And again, that's understandable, but she, the healthcare professional, couldn't give me answers. I wanted answers to things and they just weren't there. So that's seeking for answers and wanting, coming from a place of needing information, but not always getting that. But towards the end, no, they hadn't given us any information as to what the disease progress would be. And in fact, nowhere along the line did I get any indication of what the disease process was. In some cases, carers didn't know where to go for answers about the dying process. I would have thought it would be better for the whole MND process to have a single liaison person. Families who felt they had a close relationship, however, fared better. And this relationship in Western Australia is highly dependent on age and packages available through the government. I won't go into details on that, but some had more access than others. I didn't know what was required, but the nurse provided me with so much information. So when the information is there, they value it. Most cancer family carers reported that they were informed quite clearly about the process, and mainly from the palliative care providers. As we got into the different stages, the nurse told us what we should be expecting. She was very good. The nurse was very good in helping me with knowing what to expect and when to expect it. So that's stage planning and information giving and going at the pace the carer and the person with cancer wanted and needed. Feeling prepared for the end of life and death. And again, I think this goes back to the talk this morning about having information in a package so people can actually get that information when they need it and raise questions and discuss in the way that they want to. Most MND family carers felt they were not prepared for the death of their family member, and it was often unexpected. In some instances, people with MND had seen a healthcare professional hours or even days before death, but families were given no indication that the death could be imminent. We had a visit from the nurse on the Friday before the Sunday when she died. She didn't say to me, she hasn't got long to go, or we ought to make some or other arrangements, which is the information I would have liked to have had. Sometimes it's hard for me to accept, because the night before, after going to the doctor, he was all right. And in the morning, I go upstairs and I find him on the floor, and that's what I don't understand. So the implications of that rumination and going over things after the death has got huge implications for the bereavement and grief experience. Sometimes families were in the midst of treatment decisions when death occurred. In the last few weeks, there was continued talk about getting a different wheelchair. There was no talk to me personally or generally that her life was in imminent danger. The night before she died, I said, well, what do you want us to sort out? Trying to get you into a hospice or something like that? We thought she had 12 months. When people with MND died, it was often sudden. I didn't understand that her life was in danger. Therefore, even when she was making these dreadful noises, I didn't realise that that was because she was near the end. In contrast, cancer family carers felt prepared for the death, or most of them, obviously because the decline was more apparent, and healthcare providers knew what to expect. The doctors just sat down and said, now look, this is what's going to happen. The nurse said, won't last long, today, tomorrow, or probably tomorrow. So I called the family members and we were with him all day. So that preparation at time for closure and saying goodbye. I knew that the signs were of the final stages, and I was aware she was going into that. She wasn't eating, and as soon as I knew she wasn't getting up for Home and Away, which is an Australian television soap opera, I just knew. I had a blow-up bed beside his bed, and I spent most of the day with him because it was fairly obvious there wasn't much time left. So that was in stark contrast. Several people from the cancer group also mentioned, through palliative care, they had dedicated counsellors working with them, and they helped them prepare for the death. So I needed counselling, and that gave me huge amounts of peace of mind, and yeah, it brought us closer. It helped us come to terms. We never spoke about it, but when we had counselling, before he passed away, he said sorry, and I said, what are you sorry for? And he said, because I'm leaving you. So it enabled those conversations. So in conclusion, what we found was, in this particular part of the study, that there were key differences that emerged of the experience of the end of life and death of people with MND and people with cancer. And this was mainly related to the supports and systems available, not to individuals, but rather to the systems that affected the death experiences and ongoing experiences after the death. The family members had difficulty accessing the information and support they needed, and they were unprepared, which was a contrast. There were obvious limitations to the study, including misspelt, possibly biased sample, and also very small numbers of participants. We probably need to use survey with vignettes and exploring attitudes. So, in terms of ways forward in the last 2 minutes, information, preparation, education for palliative care and MND health professionals, which is happening and it is ongoing. Also effective communication training. This happens in oncology, certainly in Western Australia. All oncologists and health professionals need to go through this training. We need to have it here as well. And also, finally, balancing the focus on life and living, which is obviously very important and was highlighted this morning, with preparation for the end of life. And I'd just like to make these acknowledgements and thank all the people I mentioned, including our funders and the association and Silver Chain Home Hospice, and also you for listening. Thank you.
Thank you, Moira. We do have time for questions. So do we have any from out there in the audience, please? Okay, I've got one over the far side there.
My name is Gunnar. I come from Iceland. I have a question with regard to what you said about the people that had close-knit family systems around them, that there was a difference in how they perceived or received information. Can you say something more about that?
It wasn't so much that it wasn't so much that people who had close family around them received more information, but rather if they got information, they could gather their family around them. They had time to do that and time to prepare. That's the point I was trying to get across. Sorry, I probably didn't make that clear enough.
Okay. Other questions? So, can I ask you one then? I mean, because you've talked about sort of systems and support. Could you just say a little bit more about how accessible palliative care services are for people with MND? In some areas of the UK, you know, it's something that we're really sort of pushing for to have a non-cancer agenda and access, but how accessible are your services?
It's on the agenda. There are moves. People are coming together. There's communication, but still access for non-malignant conditions generally, and certainly for MND, the access is limited, and you know, partly because of the trajectory and the unpredictable nature of the disease, but also the lack of education, experience. The less people you see, the less experience you have, and the reluctance to really go there and actually do that work. But it is coming, but it's very, very restricted and limited at the moment.
So what's being done at a strategic level to address that, practically?
Strategic level, really just the organisations coming together, and there's now a working group, a panel that meets very regularly, and the education's happening. So the palliative care education providers, which is through the Cancer Council of West Australia, now provide education for MND, people working with people with MND, and also palliative care providers. But it's very slow. At that systemic level, there's not that much going on. It's really the interest and involvement of individuals.
Okay, thank you.
Thank you.
Any further questions out there at all? None? Yeah, okay. Rod?
Sorry. Is that back on the stage?
I was waiting for Carol to leap up, but that MND Australia and Palliative Care Australia has just signed a joint statement on palliative care and motor neurone disease. And I think the issue about palliative care and motor neurone disease, or ALS, varies from state to state. And that's one of our problems, the lack of consistency that we're able to generate. But we're hoping that the national agreement between the two national organisations will actually be a stepping stone to make change. And if people would like copies of that, I'm sure it'll be on the MND Australia website if it's not already.
Yeah, and that's essential. Otherwise, it's just individuals coming together. That's great.
And do we have a final question anywhere? No?
Thank
Okay,
you.
then join with me, please, and thank you, Moira, for her presentation.